Hello, my name is Wilma Ayala, and the topic I selected for my tech talk is the use of medical procedure simulators. Ahmed and Disri expressed that the healthcare simulation stemmed from the principle of never the first time on the patient. And throughout history, healthcare students have relied on various forms of simulation to supplement their training. Changing attitudes towards patient safety and diminishing practicum sites led to the development of more advanced simulation training modules and models. The era of modern medical simulation has been inaugurated by the work of Peter Safar, who lost his daughter at the age of 11 from an asthma attack. He then dedicated his life to the development and improvement of resuscitation techniques and cardiorespiratory maneuvers. In the early 1960s, Dr. Safar teamed up with Asmund Lerdahl, a Norwegian toy manufacturer, to develop what would become the first cardiopulmonary resuscitation dummy. This is the world-famous Resuscitation. Establishing a common medical reference for resuscitation in our time began in the USA. In 1966, a national conference recommended that all professional health personnel be trained in CPR. The first step towards internationally common practices was taken in 1967 by a symposium in Norway. It recommended that the population at large be trained in mouth-to-mouth resuscitation. Also in 1967, the World Federation of Societies of Anesthesiologists published the first comprehensive description of basic and advanced life support. The booklet was written by Peter Safar and published and printed by Lerdahl in 12 languages for worldwide distribution. Then in 1974, the American Heart Association published their standards for practicing and teaching resuscitation as a supplement to the Journal of the American Medical Association. Supported by Lerdahl, these JAMA guidelines and a series of later updates were distributed in millions of copies throughout the world. In 1967, Abrahamson and Denson presented the first computer-guided dummy, the SIM-1, intended for anesthesiologists in training. Together, these two researchers from the University of Southern California would mark a decisive turning point in the history of simulators by inventing the current ancestor of high-fidelity Mannequin. Around the same time period, an American neurologist, Dr. Howard Barrows, introduced the concept of the standardized patient by using an actor simulating a patient with sclerosis. The use of standardized patients was quickly adopted by North American medical schools. At the beginning of the 2000s, the simulation that was initially intended for anesthesia and resuscitation will be extended to other specialties, such as emergency medicine and its use of trauma simulators, obstetrics and the use of birthing simulators, and other various disciplines. The explosion of digital technology will allow the emergence of the first virtual reality technologies dedicated to medical use and the subsequent rapid growth of simulation centers in the world. Why procedural simulators? Simulators can range from low, mid, to high fidelity and have become increasingly essential to simulation-based healthcare education. Learners who have acquired the cognitive portion of training also need hands-on practice to complete the learning cycle. The use of medical procedure simulator offers an interactive learning experience where participants can engage in deliberate and repetitive practice for mastery learning without risk to patients. Shanks and his team conducted a study involving 128 medical residents to assess learner preferences for how simulators should be used in a procedural curriculum. Findings from the study showed that participants value simulator-based procedural teaching in the form of small group sessions and that simulators should be an integral part of medical procedural education. Most responders felt that simulators are effective in relation to technical skills, whether that may be to learn technical skills for the first time or to refine technical skills and also to acquire procedural teaching skills. Procedures that were considered to be most effectively taught by simulators include central venous catheterization, thoracentesis, intubation, lumbar puncture, and paracentesis. With regards to course format, majority of the respondents felt that there should not be more than 3 to 4 learners per simulators, with an instructor-to-learner ratio of 1 to 3 or 1 to 4. From the perspectives of study participants, the role of instructors should include a demonstration of technique, observing learner techniques, teaching evidence behind procedural steps, and providing feedback. Commonly cited barriers to procedural teachings were limitations in time, numbers of instructors and simulators, and the lack of realism of some simulators. I would now like to talk about the state of the art in medical simulators. Today, there are various forms of simulation modalities with or without different kinds of technologies in order to replicate the key aspects of the real world. These modalities include standardized patient actors, part-task physical trainers, virtual reality and visualization, and mannequin-based simulation. Often, the best way to replicate the human being is with a human being. These are called standardized patient actors, who are specially trained actors used to evoke many aspects of the real clinical world. The next modality involves the use of part-task physical trainers. These are used for many purposes, especially for learning particular skills by replicating specific portions of the patient or task. This technology has evolved to a more advanced form by using hybrid programs which combine a part-task physical trainer with a live standardized patient actor. You can see here how the pad was strapped on the arm of a standardized patient for teaching and learning how to suture wounds while also applying communication skills. Virtual reality and visualization involves learners interacting with a synthetic or virtual environment that exists solely in the computer, or it can be a fully immersive environment where the participant is immersed in a virtual world that fully replicates at least 3 sensory inputs: vision, hearing, and touch. The mannequin-based patient simulation takes immersive simulation further and allows the creation of realistic physical clinical environment using mannequin simulators that can replicate human functions such as breathing, vocalizations, and pupil response. These advanced patient simulators come with software that enables the display of electronically monitored information, for example, EKG rhythm, and oxygen saturation. The next thing I'd like to address is how medical simulators relate to modeling and simulation. The benefits of training fine motor skills by utilizing a series of simulated procedures are clear, but a crucial component which contributes highly to successful simulation tends to be overlooked, and that is the anatomical model. How a medical simulator relates to modeling and simulation can be exemplified by this epidural and spinal injection model. that has an extremely realistic haptic feedback as the learner simulates the skills of performing a spinal tap. This model has a fluid-filled spinal canal with realistic outflow rate and also gives the learner a realistic feel of the resistance of the dura and arachnoid matter with or without a cannula. The next thing I'd like to address is the use of medical simulators, as well as to explain why medical simulators are important. Medical simulators are used to educate and train healthcare professionals on specific clinical skills. They are sometimes referred to as patient simulators and have levels of realism from low, mid, and high fidelity. Medical simulators represent parts or full-bodied live mannequins that react to learner actions with real-time physiological responses as if they were real. These simulators help students and clinicians practice and master their clinical skills. This simulated clinical experience helps alleviate the risk of error and potentially life-threatening outcomes to real human patients. Let's talk about the future of medical simulators and where medical simulators are headed. The frequency and magnitude of disasters have increased significantly over the past 30 years. Global health threats, both man-made and natural, require a prepared and flexible healthcare provider workforce ready to respond to current or emerging crises. We are facing threats from infectious diseases, epidemics, and pandemics, including bioterrorism. We are having to learn new skills and knowledge that must be adapted to dynamic situations, particularly infectious disease outbreaks. We also have to perform in resource-constrained environments, requiring adaptation of unfamiliar crisis standards of care, such as we have gone through with the COVID-19 pandemic. Preparing for the future means that we need to develop new paradigms for training. We are seeing a growing number of computer screen simulations, high-fidelity mannequins, and virtual reality simulators, which have expanded the number of procedures and disaster conditions that can be effectively simulated. Advanced technology has been engineered into large-scale production of simulators capable of modeling a wider variety of clinical scenarios. The bottom line is that innovative education technologies, including simulation, can be leveraged as a global health security force multiplier. The next thing I'd like to talk about regarding the future of medical procedural simulators involve the development and use of minimum viable simulator, the physical resemblance of simulators, and having a common language. Svensson and Eicham wrote a narrative review on making decisions regarding medical simulators in connection to the curriculum. The recommendation was made to start with minimum viable simulator. It is the same concept derived from product management, which is minimum viable product. The author suggests that we should be open to acquiring minimum viable simulators that have only the core features for practicing a specific task and the potential to grow eventually into something big and the ability to have additional features added or functions included over time. The minimum viable product approach allows for validated development of simulators, and the user's needs can likewise be validated by pilot trials. Educators tend to favor simulators with high levels of physical resemblance. The caution here is that higher resemblance adds to simulator complexity and creates a higher cognitive load on the trainee, which can be overwhelming and therefore diminish the learning experience. It is recommended to have simulators that are designed to allow for progression to different levels of difficulty, that is, simple to complex simulators, and to keep this in mind when designing simulators and deciding on medical simulator requirements. According to Svensson and Akem, we are also faced with a lack of common language. The terms simulation, fidelity, virtual reality, and validation often confuse the development of medical simulators. The production of medical simulators is typically a polytechnical venture with creators from different expertise, such as materials science, computer science, biometry, physics, electronics, educational research, and medicine. Cross-professional communication can be challenging, especially as one word might have different meanings between each profession. Fidelity, for example, has different meanings not only for manufacturers but also for learners. Fidelity is not a constant property. That is, people do not see the same properties when presented with a simulator. The perceptual awareness, for example, the application of vision, touch, hearing, smell, and taste of an expert clinician versus a novice cannot be considered the same. So for these two, fidelity means differently. I want to thank you for your time, and I hope you got something from my presentation.